I'm start to present my presentation. So first of all, I would like to thank you for all your time and your opportunity that has been given to me today. So my name is Rizky Wardani. I'm from Indonesia, and today I would like to present and gather to discuss with all of you the case report of my research titled Management of Henox Cloyne purpura with Gastrointestinal Manifestation in the Children. So the patient I met while on duty and Dr. Saidiman Magdatan is Java around June 29, 2022. So I will start with the objective of this case report. The first is analyze the patient clinical manifestation and make a diagnosis based on the available data. And the second, to discuss the background diagnosis criteria and determine the treatment of HSP. The third, evaluate HSP literature by connecting patient cases to the management provided. So I will start with this case. With this case is a patient 10-year-old boy came to emergency room complained of diffuse abdominal pain with purpuric petechial skin lesion. So the rest started on his legs and progressively extend to his hand, thigh, buttock, and back 6 days before hospitalization. And the rest color was red to blackish with a prominent lesion, palpable, no itchy, and no pain. So I asked a little more about his history that he complained of brownish black stool 2 times, followed by severe abdominal discomforting around the lower right abdomen, like a being twisted around 50 to 30 minutes, sometimes associated with bowel movement 2 days before admission. And he continued a fever episode, fatigue, palpitation, flushing, sweat, nausea, dizziness, vomiting, and loss of appetite. And he also reported that he complained of developed with discomfort, pain, and swelling in the knees, and it caused him incapable to walk, and it be worsened with activity. And shortly after, 6 hours before admission, he complained of vomited 6 times with 2 times of hematemesis. Then I moved to that he has past medical history of acute respiratory infection around 2 weeks before the first day of the complaint appeared, and it happened around the 2nd June 2022, and he denied other infectious diseases or allergies. And for his family has denied having a history of similar complaints, infectious disease, and allergies. And he also have a medical history that he consumed paracetamol, omeprazole, domperidone, and multivitamin from the clinic 3 days before admission. And for his prenatal maternal and his birth story was normal that he was born in the hospital with perpagam process in 38 weeks gestation time. And according from his mother, that the baby has a condition with no congenital defect were reported. And he have a history already complete. Then so he kind of have a review system, so I just go over it briefly. That he has a fatigue, fever, flushing, sweat, nausea, palpitation, and dizziness, followed by a severe abdominal pain with a brownish black stool 2 times. Then he have a vomiting for 6 times with 2 times of hematemesis, 6 hours before admission, and loss of appetite. That continue with his complaining discomfort, pain, and swelling in the knees, and continued that he have a purpuric petechial skin lesion, red to blackish in color, prominent, palpable, no itchy and no pain on his legs, progressively extend to his hand, thigh, buttock, and the back. Then, since being in the ER, his vital sign appears stable. The blood pressure got 110/95, respiratory rate 20 times per minute, heartbeats get 97 times per minute, and the body weight examination got 37 kilograms. And for the physical examination showed the general state of this patient seems composite, sick but alert. And for head, eye, ear, nose, throat, examination was normal. The head looked normocephalic, anemic conjunctiva, palpebral edema, stomatitis, bleeding gums, swelling, pain, or enlargement tonsil or lymph nodes were denied and not found. And for respiratory examination, there is no respiratory distress and clear auscultation, no bronchitis or no wheezings. And for cardiac examination, for normal heartbeat and no murmur. And for gastrointestinal examination, were normal bowel sound, no distended, and I found a diffuse painful without rebound tenderness in epigastrio. So continue for the last part is extremity examination. We got non-cleansing palpable erythematous purpura, not relieved by pressure, with intermediate in size between miliary and lenticular, diffusely spreading from the feet going to hand, head, back, and buttock with indenting border and no tenderness. So we move to the laboratory examination that we can see in this screen show an elevating hemoglobin got a 16.4, hematocrit 47.3%, erythrocyte got 6.3. The increase of this risk factor is normal because in HSP it resulted from the event of inflammatory activity, which led to increased oxidative stress process that caused erythrocyte membrane damage, disrupted erythrocyte metabolism, and reduced erythrocyte lifespan due to leukocytoclastic vasculitis process. Then we also found an increase of leukocytes, 16,800, platelets 620,000, neutrophil segment 84.6%, and monocyte 9%, are due to the inflammatory process and IgA-mediated infiltration in the small blood vessel. And then we continue to histopathologic examination show hyperkeratosis, red blood cell extravasation with distribution of squamous epithelial cells, along with extensive neutrophilic inflammatory cells and lymphocytes. So, based on data before and clinical manifestation, physical examination, laboratory and histopathology examination, this 10-year-old boy patient was diagnosed with HSP or Haydock-Sploin purpura. And for the treatment, he got assessments such as hydration therapy with half the intravenous fluid, followed by supportive therapy like ranitidine intravenous, ondansetron intravena, and then continue with methylprednisolone 55.5 milligram intravena on the first day till third day, and followed by methylprednisolone 8 milligram tablet for 3 times a day at third day till sixth day. Then the dose was slowly reduced, and this patient already treated for 6 days and showing a significant improvement on his condition. So we continue to discuss about what is Haydock-Sploin purpura or HSP. So HSP is autoimmune disease of IgA-mediated hypersensitivity vasculitis, characterized by systemic vasculitis in the children, so involving inflammatory infiltration of polymononuclear leukocyte and the small blood vessel, followed by IgA1 immune deposits. So for prevalence of EHP commonly affect children aged 2 till 11 years old, and the prevalence of approximately 3 till 27 cases per 100,000 children, and the higher occurrences in males than females. Then we move to the etiology, and the trigger of HSP remains unknown, but some researchers found the connection between HSP and infection. And 50% of patients HSP have an acute upper respiratory infection history, with the most common causes: first, group A beta hemolytic streptococcus; second, the Staphylococcus aureus and Mycoplasma. And mostly group A beta hemolytic streptococcus found in 20 till 50% patient with serologic or bacterial culture. And this patient is suspected that EHP originated from upper respiratory tract infection because this patient had the symptom of cough, runny nose, and fever 2 weeks before the redness on the body appeared. And for pathogenesis, the main of HSP, it causes ischemia and hemorrhagic process, where HSP arises from the infection history, whereas its activated immune complex deposit and complement activation led to local inflammation infiltration of polymononuclear leukocyte, and it caused the formation of predominant IgA1 immune deposit in the arterioles, capillaries, and venules. And then it's continued to the necrosis blood vessel. So this process, we can call it as leukocytoclastic vasculitis. Then IgA complex created and deposit in the skin, kidney, joint, and abdomen, and it causes various manifestation. Like in the skin, we have a non-pruritic erythematous macular rest, which rapidly progress to petechiae or purpura with non-thrombocytopenia, or we can call it as non-glancing cutaneous hemorrhage in the skin. And in the kidney, it can cause nephritis. In the joint, it can cause arthritis symptoms, and for GI tract, it can cause severe abdominal pain. So all of this process is apparent and relevant in the symptom and clinical manifestation in this patient. So I move to the clinical features that there is some clinical features of ESP. The first is for the skin lesion. It starts from the symmetrical erythematous macular eruption that often located in the area that depends on the pressure, like lower extremity, bedline, buttocks, and it's possible to extend to our outer arms. And usually within 12 till 24 hours, the macles will transform into palpable purpuric lesion with thrombocytopenia. And this sign can be taken as an acute sign and hallmark of EHP in the early diagnosis. And usually the lesion changes gradually disappear around 10 days. And this sign is the same what happened with this patient. The rise started in his legs, then extend to his hand, tight buttock, and backs 6 days before admission. And then for gastrointestinal manifestation, usually occur after the skin lesion around 1 and 4 weeks after onset and found in 35 till 85% of cases. And GI manifestations such as diffuse abdominal pain may be followed also by nausea, vomiting, and GI bleeding like hematemesis, melena, or bloody diarrhea. And this can progress to acute GI, which could be severe, life-threatening, and related to prolonged hospital stay. And then and this patient complains severe abdominal pain, like a brownish black stool 2 days, 2 times, vomiting 6 times, with followed by 2 times of hematemesis and lost appetite. Then the third is joint complaint, whereas it's a common feature and a part of systemic vasculitis. And the symptom manifestation are arthralgia or arthritis, estimated occur in 70 till 90% of patients. The knees and the ankles are the most affected than small joint. And the symptom arthritis include the swelling, warm, or tenderness. Like this patient is correlation with a patient complaints such as he have a discomfort, pain, swelling in the knees, and it causes him incapable to walk. And the last is renal involvement that we can find in 30 till 50% of cases and play a significant role in long-term prognosis of the disease. And it characterized by hematuria with or without proteinuria, HSP, glomerulonephritis leading to renal failure. However, this sign of renal impairment we are not found in this patient. Then we move to diagnostic criteria. There is two of diagnostic criteria of EHP. The first is ACR criteria such as first palpable purpura, second age onset. Usually it happens around under 20 years old. Then third is acute abdominal pain, and fourth skin biopsy usually results showing granulocyte in small arterioles or venules. Then the secondly, Euler or new European against rheumatism developed criteria for the diagnosis of HSP. First is purpura with lower extremity predominance. Second, acute abdominal pain. Third, arthralgia for renal abnormalities. And the last is histology showing leukocytoclastic vasculitis. Basic on the data that we heard before, that this patient already fulfill the criteria of EHP according to ACR or Euler, such as age of onset, palpable purpura, acute abdominal pain, arthralgia, along with the supportive laboratory that we found delivering leukocyte and platelets. With skin biopsy results show hyperkeratosis, red blood cell extravasation with the distribution of squamous epithelial cell along with extensive neutrophilic inflammatory cells and lymphocytes compatible with leukocytoclastic vasculitis. So it can be concluded that this patient has been diagnosed with HSP or henoch-Scoline purpura. So we move to the management of therapeutic approach. That the first is supportive therapy is really important. That the treatment of EHP involve hydration, pain management, and give the corticosteroid. Like in this case, the patient has been given ivivloid, ranitidine, and ondansetron as supportive treatment. And the main is the role of corticosteroids like a prednisone or methylprednisolone are common given for managing HSP, especially GI sign with renal impairment. With the initial dose, prednisone at 1 till 2 milligram per kilos per day for 7 till 14 days can help reduce the symptom and lead to significant improvement in this patient condition. Like I've said before, that the dose that it's given to this patient is methylprednisolone was 55.5 milligram IV for 3 days, followed by methylprednisolone 8 milligram tablet oral 3 times for 4 days. Then the dose has been reduced gradually. And this treatment led to rapid improvement with the complaint, and the patient was hospitalized for 6 days. And for the complication, HSP complication can happen such as gastrointestinal disorder involving edema, erosion, or bleeding, along with manifestation of vasculitis in the central nervous system, lungs, testes, or renal impairment. Therefore, emphasizing the importance of monitoring for complication, the potential of recurrence, contributing the comprehensive patient care and long-term of prognosis. And therefore, the last is prognosis. HSP has generally good prognosis with the high spontaneous recovery rate with a few weeks after onset, and usually around 4 weeks after onset. And particularly in children, HSP gets recover in 94% in the children, and for adult around 89%. So like this patient was hospitalized and got treatment for 6 days and his condition was improved. And then for the last time, we have a conclusion that HSP is a systemic vasculitis primarily affecting injured children, characterized by inflammation of small blood vessel with IgA1 immune deposit. That the case of 10-year-old boy, based on the medical examination, the patient diagnosed with HSP or henoch-Scoline purpura with gastrointestinal manifestation, and the patient show improvement after 6-day hospital stay, indicating a positive response and supportive and corticosteroid therapy. Okay, that's all for my presentation. Thank you for listening. Thank you. Okay.
Thank you so much, Doctor. That was a really great presentation.
Good afternoon, all the respectful doctors and audiences. I'm Dr. Sapiwen from Myanmar. It's my honor to have opportunity to present in this international webinar. I'm going to present my paper with the title of Usefulness of Pleural Fluid Ferritin in Differentiation of Malignant and Non-Malignant Pleural Fusion. Firstly, I will introduce a brief literature on pleural fusion and ferritin. So as we all know, pleural effusion, it is a common medical problem we encounter in daily clinical practice, and it has significant morbidity. It affects over 3,000 people per million population each year. So for the worldwide, approximately 24 million pleural effusion cases per year, which is a significant number, and it's also have a high burden in our clinical practice. So pleural effusion, we can put them into two main groups. One is transudate and one is exudate. Transudate not usually caused by pleural diseases. They are as a manifestation of systemic diseases like heart failure, renal failure, and cirrhosis. For exudate, these are mainly caused by pleural diseases of various etiology like infections, either bacteria, TB, viral, or it could be due to malignancy, inflammations, autoimmune conditions, and many, many things. So to guide our management plan better, it is important to differentiate exudate into two major groups. It is due to malignant causes or it is due to non-malignant causes. In working out a case of pleural effusion, the most important investigation is we have to do pleural fluid analysis. It is a quick and minimally invasive way to get the diagnosis, and it is performed in almost all cases of pleural effusion, especially exudative pleural effusion. Pleural fluid analysis include checking its appearance, measuring pleural fluid protein, doing cytology examinations, smears, and cultures. From pleural fluid analysis, if we want to diagnose malignant pleural effusion, the pleural fluid cytology have a yield of 60% positive rate. If we do closed pleural biopsy, it alone give only 45% positive rate. Pleural fluid cytology has better yield than the closed pleural biopsy. Now, when we combine these two, both pleural fluid cytology and the pleural biopsy, the yield increase to 79% positive rate. Even after complete diagnostic workup for pleural effusion, like we take history, examinations, all the necessary basic tests, and the pleural fluid analysis. Even after this, 15% of pleural effusion, we cannot find out the exact cause of it. In such circumstances, we need to move on to more invasive, complicated, expensive tests. So before moving on these themes, measuring pleural fluid tumor markers have a tempting role as they are not invasive and then they aid to differentiate malignant from non-malignant causes. And pleural fluid ferritin, it is one of the available tumor markers that can be used nowadays. So I would like to explain a bit about ferritin. Previously, it was only known for iron storage function and iron homeostasis and metabolism. Now, it is increasingly known that ferritin also plays a role in many, many conditions, including inflammation and a variety of malignancy. So I'm going to explain about the mechanism why ferritin is increased in malignant pleural effusion. Yes, I'm going to explain on this matter. I'm going to introduce why this has happened, but I would like to ask some help from the attending doctors or the doctors. Does anyone have any idea why ferritin might have been increasing malignant pleural effusion? You can either answer with voice or in the chat box. I'm really appreciate your answer. Okay, this might be very new to you. I'm not sure. So I'm going to, anyway, thank you very much for your interest. I would like to explain the mechanism why ferritin is increased in malignant pleural effusion. Definitely, it is due to in situ protection from the pleura. It is because of malignant cells can stimulate ferritin synthesis, and tumor necrosis factor also increase synthesis of subunit H of ferritin. And in pleural effusion, malignant pleural effusion, it contains red blood cell. When there is hemolysis of this erythrocyte, there is also release of ferritin in it. And malignancy is also a kind of inflammation. So as a part of the acute phase reactant, there is increased synthesis of ferritin. All these mechanisms can cause increased concentration of ferritin in malignant pleural effusion. So this is according to the literature and theory point. So here is the question. Can we use pleural fluid ferritin in differentiation of malignant and non-malignant pleural effusion? So this study, it is designed to determine the usefulness of pleural fluid ferritin level to differentiate exudative pleural effusion into malignant and non-malignant cause. The aim of the study is to study pleural fluid ferritin level in exudative pleural effusion, and objectives include to measure pleural fluid ferritin level in patients with exudative pleural effusion, to find out the proportion of malignant pleural effusion cases among exudative pleural effusion, to compare pleural fluid ferritin level in malignant and non-malignant exudative pleural effusion, and finally, we would like to determine the cutoff value of pleural fluid ferritin level between malignant and non-malignant exudative pleural effusion by using the RC Kaufman table. So this is the research methodology. It is a hospital-based cross-sectional analytical study. Study period was 1 year from January 2016 to December 2016. The sample size was 85 cases of exudative pleural effusion. Study population were people with exudative pleural effusion admitted to study hospital, New Yangon General Hospital, and Yangon Specialty Hospital, Myanmar. Patients with confirmed exudative pleural effusion admitted in study hospital were included in the study. We exclude these cases. Patients with transudative pleural effusion, as this is not the main part we would like to study, and patients with frankly purulent fluid or chylothorax were also excluded. These are the working definitions in this study. Exudative pleural effusions, we regarded it one pleural fluid protein more than 3 grams per deciliter. Effusion is defined as malignant if one of the following present, either cytological demonstration of malignancy in pleural fluid or histological demonstration of malignancy in pleural biopsy or tissue biopsy, for example, bronchoscopy biopsy, or radiological evidence of cancer in CT test. If pleural effusion doesn't meet these criteria, it is regarded as non-malignant. This is the working algorithm used in the study. Patients with pleural effusion admitted to study hospital. Firstly, we take history, physical examinations, and we can think this is a suspected case of exudative pleural effusion or not. For the suspected cases, we proceed to the pleural fluid analysis, including routine examination, acid-fast baseline, and the cytology examination. From the fluid analysis data, if it is protein more than 3 grams per deciliter, it is confirmed exudative pleural effusion, and we measure pleural fluid ferritin level. On the other hand, exudative pleural effusion are mainly caused by pleural diseases. So we need to work out more to reach to the correct diagnosis. Pleural biopsy and other investigations like imaging, computer scan, bronchoscopy, biopsy, and from these investigations, we can differentiate them into malignant cause and non-malignant cause. After that, pleural fluid ferritin level was compared in malignant pleural effusion and non-malignant pleural effusion group. So I would like to share some of the important results of my study. When looking to age distribution of patients, obviously, malignant pleural effusion patients were in older age group than the younger age group. And in this study, 55.3% of female patients and 44.7% of male patients were included. So it is a fair gender distribution. And regarding with the smoking status of patient, if we relate with the malignant and non-malignant pleural effusion, we can see here, this is malignant pleural effusion cases. 73.5% of patients with malignant pleural effusion had smoking exposure, either actively smoking or ex-smoking. So this is a significant relationship. In 85 cases of exudative pleural effusion, 58%, 49 cases turns out to be malignant cause, and 42% were due to non-malignant cause. And this is the appearance of pleural fluid. When we do the study, the main appearance were straw and the blood stain. So when we relate this with the malignant and non-malignant pleural effusion cases, we can see here, all the bloodstained pleural effusion in this study were caused by malignancy. That among the straw color fluid, 1/3 of the patient with straw color fluid say it is caused by malignancy. This is the pleural fluid ferritin level in exudative pleural effusion, all 85 cases. The mean value was around 2068.31 nanogram per ml with a minimum value of 143.8, maximum value of 10,125. This is the most important part of my study. Mean pleural fluid ferritin level, we compared it in malignant and non-malignant. We want to know it is significant or not. So mean pleural fluid ferritin level in malignant pleural effusion was 2,870.43, while non-malignant pleural effusion mean value was 1,066.09. The data were analyzed, and it is proof that mean fluid ferritin level in malignant pleural effusion was significantly higher than that in non-malignant pleural effusion. P-value was less than 0.1. And after that, we need to determine the optimal cutoff value of pleural fluid ferritin for malignancy. So we use the reservoir operating characteristic table and then cuff. And the result was the optimal value cutoff point was 1,437.7 nanogram per ml. It has sensitivity of 75.5% and specificity of 77.8% for malignancy. So to sum up, this study proved that pleural fluid ferritin level was significantly higher in malignant than in non-malignant pleural effusion. Above the optimal cutoff point of pleural fluid ferritin, it has 75.5% sensitivity and 77.8% specificity in detecting malignant pleural effusion. Now we can consider here, is this sensitivity and specificity is good enough to be used in pleural fluid ferritin as the main task in differentiation. Actually, it is not too strong, and at the same time, it is also not too poor. So measuring pleural fluid ferritin alone cannot correctly identify or exclude malignant pleural effusion, but it is an easy, effective, and inexpensive way to differentiate these causes. And it will be better, more effective, more accurate if we combine considering together with the clinical context and routine pleural fluid analysis result. So we can finally, we can conclude that raised pleural fluid ferritin level above the optimal cutoff value, it is a good indicator in differentiation of exudative pleural effusions into malignant and non-malignant causes. And that it can help us in guiding better management for our patient. So these are the main references of the study. And it's time for question now. I'm happy to answer any questions and queries. Thank you very much.
Good afternoon, everyone. I am Dr. Nushiwa from Myanmar. Today, I'm going to present about my thesis, which was done for my master degree for medical science and pharmacology in University of Medicine 1 in 2020. The title is vancomycin, the ratio of plasma trough concentration to minimum inhibitory concentration and microbiological outcome in hemodialysis patients with end-stage renal disease. For introduction, hemodialysis is one of the treatment options for end-stage renal disease, and it is recommended to achieve improved quality of patients' life. Infection is the second leading cause of death in patients undergoing chronic hemodialysis. The presence of central venous catheter and radiovenous arterial graft causes patients more prone to infections. The central venous catheter-related and arteriovenous graft-related infections are responsible for 30% of causes of hospitalization due to infections in hemodialysis patients. There are many bacteria causing bacteremia in hemodialysis patients. Among them, gram-positive bacteria are the commonest organisms, accounting for half to three-quarters of causes. 50.9% of hemodialysis vascular access-related bacteremia and 25.9% of hemodialysis catheter-related bacteremia are caused by Staphylococcus aureus, including methicillin-resistant Staphylococcus aureus. And 8.9% of hemodialysis vascular access-related bacteremia is caused by Enterococcus. Vancomycin is the mainstay treatment for MRSA infection at the time of study, and it has a wide spectrum of activity against gram-positive infection. It is a large tricyclic glycopeptide antibiotic having a molecular size of about 1,450 dalton, and it is mainly excreted and changed in the urine. So total body clearance is dependent on the functions of the kidneys, and there is a risk of nephrotoxicity if it is used in patients with impaired renal function. In patients with end-stage renal disease, its clearance out of the body is totally dependent on hemodialysis. The clinical efficacy and safety of vancomycin has been evaluated by pharmacokinetic and pharmacodynamic indexes, such as time that the concentration of vancomycin remains above the minimum inhibitory concentration, the ratio of the area under the serum drug concentration on versus time curve and MIC, and the ratio of the maximum serum drug concentration and MIC. The plasma trough concentration of vancomycin, C-trough, has been regarded as the most practical method for therapeutic monitoring of vancomycin, especially in patients undergoing hemodialysis, as the only blood sampling time before the mixed dose is required. The adequate plasma trough concentration of vancomycin before the mixed dose proves that the plasma concentration of vancomycin is above MIC throughout the time course between doses. The acceptable therapeutic range of plasma trough concentration of vancomycin, according to the references, is 5 to 20 milligrams per liter. The objective of this study is to determine C-trough MIC ratio and the microbiological outcome of vancomycin in hemodialysis patients with end-stage renal disease. This is a hospital-based observational study done in 19 patients within a study period of 1 year, January 2019 to December 2019. This is a study flowchart of study procedure. Patients with end-stage renal disease who undergoes hemodialysis twice per week, who were going to be prescribed intravenous infusion of vancomycin by nephrologists for the bacteremia of gram-positive bacteria, whose culture and sensitivity results has MIC value of vancomycin were recruited, then written informed consent was taken. 3 ml whole blood sample was collected immediately before administration of the dose of vancomycin infusion during hemodialysis, that is the steady state concentration. Then vancomycin trough plasma concentration was measured from that sample using the HPLC-UV method. Then C-trough MIC ratio was calculated. Microbiological outcome was evaluated by the blood culture and sensitivity test after completion of the fifth dose of vancomycin according to IVSC guidelines. Let's go on to the results. Table on the next slide show the type of dialysis used, C-trough MIC value, microbiological outcome of the individual hemodialysis patients with end-stage renal disease. In the second column, you can see that 12 patients use the low flux dialyzer, whereas the rest of the patients use high flux dialyzers. In the third column, there is a wide dispersion and C-trough value can be seen ranging from 4.4 milligram per liter to 69.1 milligram per liter. On accounting MIC value, 4 patients has MIC value of 0.5 and the rest of the patients has that of 1, showing that these gram-positive bacteria are sensitive to vancomycin. Regarding C-trough-MIC value, there is also a wide dispersion can also be seen as in C-trough level. Regarding microbiological outcome, 12 patients has derived blood culture and sensitivity results, and the rest of the patients are positive for gram-negative bacteria, which are not included under the spectrum of vancomycin's activity. Then, in the left figure, we categorize the plasma trough concentration of vancomycin into 3 levels, that is therapeutic level 5 to 20 milligram per liter, subtherapeutic level less than 5 milligram per liter, and supratherapeutic level above 20 milligram per liter. 8 patients had therapeutic level of vancomycin, whereas 2 patients had subtherapeutic level and 9 patients had supratherapeutic level. Then, C-trough-MIC ratio was categorized into three groups in the right figure. That is 5 to 20 therapeutic value, less than 5 subtherapeutic value, and above 20 supratherapeutic value. Although 8 patients had within the therapeutic level, only 5 patients had C-trough-MIC therapeutic value, and 2 patients had subtherapeutic value, and the 12 patients had supratherapeutic value. Let's go on to the discussion. We can clearly see that C-trough of vancomycin of patients were obviously dispersed in value ranging from 4.4 milligram per liter to 69.1 milligram per liter. Among 90 patients, 8 patients received acceptable therapeutic range, 2 patients had subtherapeutic level, and 9 patients had supratherapeutic level. 2 facts are considered to explain that wide dispersions of the C-trough level. The first one is dosing regimen. In the study, the same dosing regimen, loading dose of 25 milligram per kilogram followed by fixed maintenance dose 500 milligram during each hemodialysis were prescribed in all patients. And this fixed dose maintenance regimens of 500 milligram administered during or after the hemodialysis sections can reach plasma trough level of vancomycin below or above the acceptable range of 5 to 20 milligram per liter according to the references. Another point to be considered is the type of dialyzer used. Vancomycin is a large molecule, as mentioned earlier. Only high-flux dialyzer can remove it out of the body efficiently. Among 9 patients with supratherapeutic level, 5 patients use high-flux dialyzer, whereas 4 patients use low-flux dialyzers. The dispersions of the supratherapeutic level of C-trough level in 4 patients using low-flux dialyzers is acceptable, but that of the 5 patients using high-flux dialyzers were not acceptable. That monitoring of plasma trough concentration of vancomycin before next dose is essential in patients either using high or low-flux dialyzers. By and by stated that it is important to monitor plasma trough vancomycin level before the dose in order to decide the dosage of vancomycin to be prescribed, and it is recommended to omit 1 dose of vancomycin if the third dose plasma trough level is above 20 milligram per liter. On accounting C-trough-MIC ratio, 1 patient having a MIC value of only 0.5 had plasma trough vancomycin level of 69.17 milligram per liter, so that this patient's C-trough-MIC ratio became 138.35, revealing that patient's plasma vancomycin concentration is extremely higher than the required amount to defeat the pathogens. This evidence proved that therapeutic monitoring of vancomycin should not only the plasma level vancomycin, but also MIC of the individual patients. By evaluating the blood culture and sensitivity results after completion of the 5th dose of vancomycin, 12 patients were regarded as sterile, while 7 patients were positive for gram-negative bacteria, which do not include under the spectrum of vancomycin's activity. In this study, only 5 out of 19 patients achieved therapeutic C-trough-MIC ratio value. 2 patients had subtherapeutic value with the possibility of development of resistant strain, and the majority of study group, 12 patients, had supratherapeutic value with the vulnerability of the acute nephrotoxicity. Although the dosing regime of vancomycin and frequency of hemodialysis per week are the same in all patients, C12 of the patients are widely dispersed, proving that plasma trough concentration before the nexus is essential to achieve the optimal clinical effectiveness of vancomycin. Therefore, this study provides an evidence of the importance of therapeutic drug monitoring of vancomycin in patients with end-stage renal disease undergoing hemodialysis. This research was funded by Department of Medical Research Yangon and ethically approved by Research and Ethics Committee of University of Medicine Yuan. Thank you so much for your attention, and any questions are able to take.
Hello, everyone. Good afternoon to the organizing committee, chief guests, all the respected participants and attendees. It is my great pleasure to have an opportunity to present the presentation in this international conference. And thank you so much for letting me to contribute in this webinar conference. So I'm Dr. Heng-Wei, you may call Dr. Hne. I'm a senior consultant, newborn and infant doctor from Yangon, Myanmar. So today I would like to do a clinical case presentation about how newborn screening program is crucially important for the infant and children's life, especially in the low-income nations where newborn screening program is not fully established. I'm going to conduct a clinical case of congenital hypothyroidism, presenting with acute intestinal pseudo-bowel obstruction with prolonged neonatal jaundice. And it was my own experience in my daily hospital practice. So that please feel free to ask any questions if you feel unclear. So let's go to the case now. So this is my hospital, 800-bedded general and teaching hospital. And let's go to the case clinical presentation. So I show the picture of the infant after the permission of the parents. So let's go to the history. Day 1 old baby boy was admitted to our newborn intensive care unit with mild respiratory distress. He was born by emergency lower segment cesarean section due to fetal distress, but with good ABGA scoring. His mother received 2 times for antenatal care and no non-medical illness, including thyroid problem, autoimmune disease, and no history of regular taking drugs. And the infant was the 3rd child of healthy and unrelated couple, and no family history of similar illness or thyroid problem in family. So when going to the physical examination, anthropometry, body weight was large for gestational age. It was 4,500 grams, that is more than 90th centile with the WHO standard centile chart. Body length is normal, appropriate for the standard centile chart. Occipital head circumference is also normal. The baby was normal appearance, well-looking big baby with mild respiratory distress, and the gestation was also appropriate for the infant. And we did some systemic examination and no murmur. Other system examination at birth were reveals normal and anal opening was present, but we noticed delayed passage of meconium more than 48 hours since at the time of birth. So we did some investigations. So mean arterial blood pressure was normal for his age. Oxygen saturation in air is 98% is normal. And there is no difference between the preductal and postductal oxygen saturation. That indicates that is low generally in one heart condition. And then on going to the chest radiograph, chest X-ray, heart size is normal. And then there is only perihilar infiltrates present in the lung field, maybe due to the secretion at the time of birth. So what are the problems during hospitalization? So the infant developed constipation with abdominal distension that resembling the pseudo-bowel obstruction after starting enteral feeding on day 3 onwards. And the baby has a condition of jaundice still persists up to day 14 days of age. And the baby was unable to feed well. And then from the 10 days onwards, we expected about the post-facies, post-cry, large protruded tongue with feeding problems and periorbital puffiness, lethargy, and dry mottled skin also. So this is picture of the baby, you can see the post facies, post cry, and then trunk is protruded, and then the skin is dry, mottled, and the tummy is distended. So we did some investigation, full blood count more or less normal, and then CRP to detect the infection, because the infection is very common in our country and it is a little bit high. So we suspected about the septic condition, and then blood sugar normal, electrolytes normal, and we did the bilirubin level for the total and split bilirubin because of the prolonged neonatal jaundice, and it comes out with unconjugated hyperbilirubinemia. So that we did some management like bowel rest and started intravenous empirical antibiotics on day 3 onwards due to high CRP, because it might be the septic ileus. But the problem of constipation and abdominal distension from the 3rd day onwards still persists and not going out, so that we did plain X-ray radiograph. And then in the plain X-ray radiograph, we can see the dilated loops of bowel with mild abdominal wall edema, but there is no sign of immediate surgical problem. So according to the history, physical examination, and some investigations, we think about the following condition. Number 1 is septic ileus. It might be the septic ileus, maybe due to high CRP. Number 2 is congenital hypothyroidism, maybe due to the host facies, host cry, and tummy, distended abdomen, and then electrolyte imbalance, and the rare thing is the metabolic disorder. So we suspected about the thyroid congenital hypothyroidism, and then we did the thyroid function test on the age of day 12, and the free T3, free T4 are low with DSH is high. It is 100 milliunit per liter, so that is a lot of high for this infant age. And then we counter check on day 14 of age, and the test is more or less the same with the day 12 of age. So we did some investigations to the mother, because there are mother's condition affecting the fetus, so that we did thyroid function test to the mother. It was normal for 2 times, 3 months apart. And then we did some DSH receptor antibody. It is non-reactive. And we did some autoimmune screen panel to the mother. It is normal. And mother is taking no history of regular taking drugs like anti-thyroid drugs, and the mother is more or less healthy mother. And we did the thyroid scan to this baby, nuclear medicine radioiodide thyroid scan reveals no radio loose tracer uptake is seen in the thyroid area, and the comment is congenital hypothyroidism, and the cause is thyroid dysgenesis. And we did some knee X-ray to detect the delay ossification center that is often occur in hypothyroidism, so that there is periorbital, proximal tibial epiphyseal ossification center is not seen in this infant, so it indicates delayed bone age. And then we did ultrasound scan to the thyroid, and only remnant of the hypoplastic thyroid gland tissue is present, and also give the thyroid dysgenesis. So for all of this, we have to conclude that the child has a condition of the congenital hypothyroidism, and the cause is thyroid dysgenesis. So this is a short video clip. You can see the post cry of the baby. So you can see the host cry. The cry is not that simple, and then post scan and post facies also. And then we diagnosed the infant of congenital hypothyroidism condition, and we started the treatment as early as possible within day 18 of age. So we did joint care with pediatric endocrinology team and our neonatal team, and we started levothyroxine T4 oral tablet according to the standard dose. And then we rechecked thyroid function tests after 2 weeks of duration. And then, so we found out that DSH reduced to 30 microunit per mil in 2 weeks. And then, so now on levothyroxine 8 to 10 microKT per day, and the hearing screen serially were normal. So this is the 9-month-old infant with normal age-appropriate milestone. He came regular follow-up to our newborn unit and then also to the endocrinology unit. And you can see the baby is well charming, looking well baby with age-appropriate milestone, with good intellectual and good neurodevelopmental outcome. So by the age of 4 years, you can see the baby is a very cute baby, very cute boy, and then he can do anything well with no mental retardation. So let's go to the very brief literature review about the congenital hypothyroidism. So it is defined as thyroid hormone deficiency at birth, and it must be diagnosed promptly because delay in treatment can lead to irreversible neurological deficits. And it is also most common preventable cause of intellectual disability and mental retardation worldwide. For the newborn screening program, congenital hypothyroidism was one of the most common preventable causes of newborn disability. And that globally, newborn screening programs have led to early diagnosis and treatment, resulting in improved neurodevelopmental outcomes. But however, in low-income nations, where newborn screening program is not fully established, untreated congenital hypothyroidism remains a significant and societal challenge. So looking to the epidemiology, worldwide prevalence is 1:3,000 to 4,000 live births. Condition is sporadic or familiar. Females are affected twice as commonly as males, and the incidence is higher in Hispanic and Asians, and also the incidence is higher in twin births, multiple births, preterm infant, and certain type of syndromes like Down syndrome, Turner syndrome, Williams syndrome, and Paget syndrome, etc. So in our country, Myanmar, thyroid disorders, hypothyroidism is not uncommon in Myanmar, and it is commonly seen in northern part of the Myanmar and the southern part, coastal region, and also the delta region, since the soil is usually deficient with iodine. But it is not related with this case, because this is due to the thyroid dysgenesis. So when going to the embryology, thyroid gland develops as an endodermal proliferation at the time of 3 to 4 weeks of pregnancy. And the thyroid hormone synthesis, T3 and T4 synthesis, begins at the 12 weeks of pregnancy. And the DRH and DSH thyroid hormone are detectable at the end of first trimester, that is within first 3 months of pregnancy. But till 18 to 20 weeks, the fetus is dependent on transplacental passage of maternal hormones because his hypothalamus pituitary thyroid axis is still immature. So what might be the causes of congenital hypothyroidism? It is mainly due to the primary cause, secondary cause, and other causes, transient causes. So the primary causes included thyroid dysgenesis and thyroid dysharmonogenesis. Secondary causes included the central causes. It is a condition that affect in the brain. So that is a pituitary or hypothalamic abnormality. And other causes might be transient due to the maternal medication passing through the placenta, maternal blocking antibodies, or iodine excess or deficiency. So when going to the thyroid dysgenesis, it accounts for 85% of the cases, and it included thyroid aplasia, that is a total absence of thyroid tissue, that account for 30%. Thyroid hypoplasia, atrophic malfunctioning is account for 5%, and atopic tissue, that is for 48%. And in my case, the cause is thyroid aplasia. And thyroid dysharmonogenesis causes, it accounts for 10% of the cases. In this case, a goiter is almost always present, and it results from the inborn error of thyroid hormone synthesis and gene mutations. I'm not going detail in this presentation because of the time limitation. So central hypothyroidism is also called the secondary hypothyroidism. It is due to the DSH deficiency, DSH unresponsiveness, DRH deficiency in the intracranial tumor, or maybe due to the DRH unresponsiveness. So this is a short photo, so that indicates the hypothalamus, pituitary, and the DSH thyroid axis. And then you can see the DRH is secreted from the hypothalamus. It affects to the anterior pituitary, and then the anterior pituitary hormone DSH affect to the thyroid gland, and then thyroid gland doing the many processing like iodination, oxidation, and coupling processes secrete T4, and then later on T3 in some target organs and affecting in the whole body of organ. So this is a congenital hypothyroidism baby. So you can see very short broad neck, protruded tongue, coarse faces, and coarse facial features. Tummy is distended. So what is the symptoms of congenital hypothyroidism at birth? So many affected babies will have no symptoms initially due to the transplacental passage of maternal T4. The earlier symptoms will be noted upon feeding and browsing, and it presents with prolonged jaundice after birth, like in my case, and later soon maybe present with a delay mastoid. And by the age of 3 to 6 months of age, if the baby is not treated, it comes with a stunted growth, short stature, short extremities, coarse facial features, thick, broad, and protruded tongue. The skin is dry and scaly, development is delayed, dentation is delayed, hoarse cries, hoarse cry, and sexual maturation may be delayed with coming with a profound mental retardation. So this is a picture of the infant of congenital hypothyroidism, and this is in a growing life. So you can see very short stature, short broad, and short extremities with a severe mental retardation, with very bad intellectual condition, and then it is also called the cretinism. So this scoring, QBAC clinical scoring, is very much important for the scoring of congenital hypothyroidism, especially in low-income nations where newborn screening program is not fully established. So you can see in this scoring, there are altogether 13 scores. And if the score is more than 4 by 13, hypothyroidism is suspected and the child is investigated accordingly. So this is the algorithm for management of congenital hypothyroidism in our country, Myanmar. And this algorithm I extracted from our Pediatric Society Myanmar guideline, because we have no newborn screening tests in national level. So we did the thyroid function test if we suspected about the hypothyroidism. So when the maternal history of taking antithyroid drugs or clinically suspected cases, or if we suspect it in clinical features, we do the thyroid function test, TSH, T4, or free T4. So if TSH is high and T4 is low, free T4 is low, so congenital hypothyroidism is definitely diagnosis, and then we start treatment as early as possible within day 18 of age. And if the TSH is high and free T4 is normal, it might be the transient or permanent mild congenital hypothyroidism, delayed maturation of hypothalamic pituitary axis, thyroid hormone resistance condition, or Down syndrome. So in that case, we recheck the TSH at 2 to 4 weeks. And in the 2 to 4 weeks, if the TSH is normal, no treatment is required, no hypothyroid. And if the TSH is persistently high, we assume that this is a condition of the congenital hypothyroidism, and then we started levothyroxine before day 18 of age and trial of therapy at 3 years of age. And then if the TSH is normal and free T4 is normal, no treatment is required, no hypothyroid, and the TSH is normal with free T4 is low, we have to consider central hypothyroidism, thyroid binding globulin deficiency, or transient hypothyroxanemia, and clinically consistent with central hypothyroidism. So that in that case, we started the treatment and cranial imaging might be needed. So this is the very useful algorithm that is adopted from my pediatric society in Myanmar. So we use this guideline currently.
नॉर्मल बोलेंगी माइक्रोफोन सामने.
Sorry? Okay, so treatment and goal of therapy. So it is important to start as soon as possible before 18 days of age to get the optimal of cognitive outcome. The goal of therapy is to normalize the D4 within 2 weeks and DSH within a month. And dosage is adjusted according to the thyroid function test. And we need the regular follow-up, monitoring growth parameters, monitoring the neurodevelopmental outcome and hearing assessment. And each and every follow-up visit, we have to do the neurodevelopmental outcome screen. So what are the key messages in this presentation? One, congenital hypothyroidism is common worldwide and is the most common reversible and preventable cause of mental retardation. So early identification is a crucial importance because the thyroid development, brain development is affected by the 3 years of age. So that in this case, universal screening, newborn screening program is ideal, as most cases are sporadic, and it may be many hidden cases. So let's go few about the newborn screening program. So newborn screening is a crucial public health program that aims to identify conditions that happen shortly after birth. And these conditions may not be clinically apparent during the newborn period, but can be detected early. The goal is to confirm diagnosis and timely interventions that can significantly affect the long-term child survival and long-term health. So this is a component of the newborn screening. So it is done when your baby is 24 to 48 hours old. So the newborn screening usually contains 3 components: hearing screen, Hilbrick screen for the test for rare genetic hormone and metabolic conditions, and also the screening for inborn heart condition, so that if we can do in time, we can manage in time. So this is a newborn screening program, a test with a Hilbrick test with a filter paper. And globally, newborn screening program is like this map. And you can see the areas shaded in dark blue is the prevalence is more than 90%. Newborn screening is prevalent, and the areas shaded in red area, that is prevalence is only 1 to 10% that is included in our country also, so that newborn screening is societal challenge in our country. So these are the disease conditions that included in the newborn screening, but in high income countries, the disease can be more than these ones. So thank you so much for your kind attention and for being here today. I really hope that my talk will be very helpful to you in your everyday practice and become awareness of the diseases that may be detected during newborn screening. So early diagnosis and timely treatment can be beneficial in many newborn illnesses to achieve a good quality of life and good survival. So thank you so much for all the participants and audiences. And if you have any questions, please ask me. I'm very happy to answer. Thank you so much.
This is the diabetes and the retinal changes in the eye and upfit to the side. So understanding of diabetic retinopathy. So in my PPT outlines, little bit clutches are present. No, next slide is not. So my presentation's outline is overview of diabetes and its types, what is diabetic retinopathy, risk factor and types of diabetes, significance of blood sugar control, symptoms and early signs, advanced stages and complications, screen diagnosis, treatment options, preventive measurements, statistical analysis on diabetic retinopathy, emerging treatment, and the other researches. So the learning object, which is we got from this PPT, recognize the importance of the diabetic retinopathy as a public health problem. and discuss diabetic retinopathy as a leading cause of the blindness in developed countries, identify the risk factor for diabetic retinopathy, and distinguish between the stages of diabetic retinopathy, and understand the role of the risk factor control and dilate examination in the prevention of vision loss. So now overall diabetes, what is the diabetes? We know that diabetes is a non-infectious metabolic disease that occurs when insulin secreted by the pancreas is not released or metabolized by sugar. So it's leading to uncontrolled blood sugar control level. It shows the diabetes, and the symptoms include the thirst, weakness, fatigue, blurred vision, and more. So diabetic retinopathy does not cause any specific symptoms at first, but over time it can develop along with other eye diseases. So you should have your eyes checked at least once in a year to protect your eyes as soon as. So usually we can see there are basically two types of diabetes: type 1 diabetes, which is due to autoimmune destruction of the insulin producing cells requiring daily insulin injections, and type 2 diabetes results from insulin resistance or irregular production. And the other type includes gestational, monogenic, and drug induced. This is gestational, it's most important. So gestational diabetes is occurred during the pregnancy due to hormonal imbalancement and increase the risk of the factor of diabetes. So for the mother and the children, and so here the sugar level is the control, and it is the crucial complication of the mother and child to both. Okay, now what is the retina? First of all, here we discuss diabetic retinopathy, diabetic retinopathy. So what is the retina? In the picture, we can see retina is a multi-layer structure where the light-sensitive new tissues, which is the lining in the inner surface of the eyeball, and light is focused on the retina and then transmitted to the brain through the optic nerve. So the macula is a highly sensitive. In the picture, we can see that there is a macula, which is the center of the retina, and it is responsible for the center vision. So macula is needed for the reading purpose, to recognizing the object and executive other activities than the fine and sharp vision. So what is the diabetic retinopathy? Diabetic retinopathy is a complication of diabetes affecting the eyes. It develops from the elevated glucose level damage the blood vessels in retina, leading to reduced blood flow, microvascular degenerations, and other formation of the abnormal capillaries. The condition progresses stages from non-proliferative to proliferative stages, which is increasing the severity of symptoms and thus including vision loss. So we can say that diabetic retinopathy should be concerned because unhealthy sugar can accumulate in the blood vessels of the retina over a time and causing the blindness. So as usual, we basically three type of diabetes. We have justice type 1 and type 2 and the gestational diabetes, and other are also including, which leads to the causes risk factor of the diabetic retinopathy. So at the stage of the gestational, risk factor shows that diabetes can lead to diabetic retinopathy. Is control necessitating the National Institute of Health reporter examination is important for the gestational stage, and type 1 is required to daily insulin injections and diagnosis in the children and teenagers. Okay. Now, what are the pathogenesis involved? So at the stage of the diabetic retinopathy, microangiopathy, which has features of the both microvascular leakage and microvascular occlusions. Here the vessels are large in size, and at the stage of the microvascular leakage, the loss of the parasites, which is results in distinction of the capillary wall, producing microorganisms which have to take the leaks, and blood retinal barrier breakdown, causing plasma constitute to lead the retina layer, and so it becomes to going on the retinal edema and hard exudates are formed. Microvascular occlusion is stage starting from the basement membrane, which is the innermost membrane of the choroid, and it becomes to going the thick, and endothelial cells are damaged, they form the RBCs, platelets, sticks. So vascular endothelial growth factor is produced by the hypoxic retina, and vascular endothelial growth factor stimulate the growth of the shunt and new vessels. So in the picture, we can see at the stage of the diabetic retinopathy, hard exudates are the form, new vessels are the form, and capillaries are the leakage, cotton wool patches are the form. These are the features. This is the macula and this is the object disc. At the stage of the diabetic retinopathy, these are the features that develop. So we can say that in diabetic retinopathy, retinal artery stenosis damage the microvascular neurons of the retina, subsequently cause microvascular degeneration of the retinal membrane. So in this way, we can say According to pathology, basically two features are involved: microvascular leakage and the microvascular occlusions are occurred. So now, what is the significance of blood sugar control? So if we control the blood sugar level, so it reduce the risk of the diabetes, also improve the overall health. Glycemia causes the damage risk, especially causes bleeding, blindness of the eye, and control blood sugar level can result in various complications. The importance of the monitoring blood sugar level is also most important factor. Okay. Now, screening. What are the screening diagnosis? So here basically we discuss on basic 4 types of screening is important in diabetic retinopathy. First one is visual acuity examination, dilated retinoscopy, fundus examination, OCT matching. Visual acuity examination is performed to assess the patient's overall eye health and ability to see the clearly, and at the stage of the dilated retinoscopy with eye drops to get a better view of the back of the eye, including the retina, nerve and vascular structures. And fundus examination is helpful to examination of the retina, vitreous, optic nerve using a specialized camera, which is capture the high resolutions of the images. So it shows the abnormality or sign of the retinopathy. At this, and the fourth one diagnosis process is OCT. OCT, that is optical coherence imaging technique, which is uses the light waves to take a cross-sectional picture of the retina, which helps in the detecting swelling and fluid accumulation. So cross-sectional image of the retina identify the macular changes. So these basic tests, which is helpful to diagnosis of diabetic retinopathy. What are the recommended eye examination schedules? So at the stage of diabetes 1, 3 to 5 years after diagnosis is the first examination, and follow-up is going on yearly. And diabetes type 2 is involved. That is, the first examination is at the time of diagnosis, and follow-up is on yearly. And if the gestational diabetes is occurred, then the first examination is prior to conception and early in the first trimester. No retinopathy to mild to moderate NPDR, that means non-proliferative diabetic retinopathy, every 3 to 12 months. If severe non-proliferative diabetic retinopathy is occurred or worse, every 1 to 3 months. So now, if we're going on the treatment plan, so at the early stage diabetic retinopathy treatment, regular checkup is essential, which is control the blood sugar level. This is the progression of disease and control the description of the disease, and also consider the first line of defense against diabetic retinopathy, as well as changing of the lifestyle such as healthy diet and regular eye exercises control to diabetic retinopathy management. And as an advanced stage, treatment is varies based on the type of retinal disease and severity. Option including injectable medications, treatment, vitrectomy is a other process of the injectable process, and advanced treatment like peptide products, stem cell therapy show promise but are still under investigation. So common treatment for diabetic retinopathy, first one is include the laser surgery, corticosteroid injections, and EGF drugs, and vitrectomy. Second one, kinase and anti-VEGF drugs are the key response of the diabetic retinopathy prevention. Third one is the surgical options are available for the advanced cases, including vitrectomy to remove the scar and the blood from the eye. And fourth one, injection of the corticosteroids or anti-VEGF because to reduce the macular edema and abnormal cells. What are the preventive measurement and patients education? So here preventive strategies encourage the maintaining a healthy lifestyle, regular exercise, balanced diet to control the blood sugar level and reduce the risk of the diabetic retinopathy. Whereas regular eye checkup too is a significance of the annual eye checkup for early detection and intervention in diabetic retinopathy to prevent the vision loss. As well as patient education form is provide comprehensive education to diabetic patient about the importance of blood sugar, adherence, medications, and lifestyle changes to manage the diabetic retinopathy effectively. So now, what is the diabetic retinopathy epidemiology? So the total number of the people with is projected to rise from 285 million in 2000 to 439 million in 2030. So diabetic retinopathy is responsible for 1.8 million of the 37 million cases of blindness throughout the world. So diabetic retinopathy is the leading cause of the blindness in people of working age in industrialized countries. So the best predictor of the diabetic retinopathy is the duration of disease after 20 years of diabetes, nearly 99% of patients with type 1 diabetes and 60% with type 2 have some-degree diabetic retinopathy, and 33% of the patients with diabetic have sign of the diabetic retinopathy. People with diabetes are 25 times more likely to become going to blind than the general population. So International Clinical Diabetes Retinoscopy Severity Scale, here we divided two types of parameters. First one, it shows the severity level, and second one is shows the dilated ophthalmoscopic examinations. What are the changes at the fundus? So at the stage of no apparent retinopathy, no abnormalities are shown, and at the stage of mild non-proliferative diabetic retinopathy, results are shown, and at the stage of moderate non-proliferative diabetic retinopathy shows more than the number of microaneurysms. The severe stage is in, okay, now severe non-proliferative diabetic retinopathy shows any of the following: more than 20 intraretinal hemorrhages in each of the four quadrant, definite venous bleeding in two or more quadrant, prominent intraretinal microvascular abnormality, that is IRMA, in one or more, and no sign of the proliferative retinopathy. At the stage of proliferative diabetic retinopathy, one or both of the following factors are included: neovascularization, vitreous or pre-retinal hemorrhages are maybe going on. So statistical analysis shows about 40 to 45% prevalence factor of diabetic retinopathy in Americans with diabetes, and the number of the patients affected increased from 108 million in 1980 to 422 million in 2040. Additionally, the disease is estimated to have seriously affected 8.5% of the population in 2040. So in 2019, diabetes was the 9th leading cause of the death. The effect of the type 2 diabetes can be controlled by eating a healthy diet, exercise regularly, controlling smoking, drinking, get regular checkups, and taking medications that lead to the treat to the problem. Okay, in the end, the last, we know what are the researches which is going on the diabetic retinopathy as an advanced treatment. We can see in the picture the peptide products and stem cell therapy show promise in treating vascular degeneration, and medical device called the mask, which limits the green light exposure during sleep, is under investigation. As innovative therapy, non-steroid anti-inflammatory drugs and long-term intravitreal steroids injections may also be considered for the macular edema, with potential side effects in like cataracts and glaucoma and so on. So here, what are the conclusion? Here, this conclusion shows the incidence of diabetes in India is increased. It's mean the impact on the eyes and manifesting a diabetic retinopathy, which can lead to cataract, neovascular glaucoma, retinal detachment, and so on. So patients who experience blurred vision while running should be concerned about visual impairment, and diabetic retinopathy is preventable through strict glycemic control and annual dilated eye examination by an ophthalmologist. So we know that diabetes and diabetic retinopathy. So diabetic retinopathy is due to the unhealthy sugar can accumulate in the blood vessels of the retina. So microvascular degeneration is a control level by the diabetic control. So at the last, we can say that there are some conclusions are that regular checkup is most important for the diabetic retinopathy by the glycemic control and as well as the annual dilated eye examinations by an ophthalmologist. So this is my little bit introduction area, my biography, and this is the references. Here are some references, some which includes the diabetic retinopathy from the research papers, and this one are the websites. Hope the things were comprehensive. Thank you. Have a good day to all of you.
Okay, my name is Endang Winiati, and my team is consists Turmi Zifat and Evi Aida Fitria. We are from Department of Oral Biology and Oral Science Center, Faculty of Dentistry, Universitas Indonesia, Jakarta, Indonesia. The title of my topic today is molecular docking of HSA microRNA 29B3P with bone morphogenic protein receptor 2 and cross-linker T4 chitosan lysozyme. So, as an introduction, the field is about tissue regeneration for bone. So bone regeneration with tissue engineering discover preferred approach because we could utilize the own human body to accelerate the cell regeneration toward osteoblast development. Here we determine the potency of the microRNA 29B3P with bone morphogenic protein 2 and cross-linker T4 lysozyme chitosan to enhance bone regeneration or to stimulate osteoblast differentiation. As can you see here, the figure is show that for good regeneration of the bone, we need such biomaterial like hydrogel, cationic liposome, nanoparticle, and lastly, we need also the growth factor that consists from the exosome. So here we can utilize a bone marrow stem cell or osteoblast to enhance bone regeneration through the incorporation of microRNA, bone morphogenic protein, chitosan, and with cross-linker T4 lysozyme. So this is a in silico study. So firstly, we utilize a non-coding RNA-based therapy for bone defect that have attracted increasing interest because the great potential of non-coding RNA in disease treatment. Various steps of non-coding RNA regulate gene expression in osteogenesis-related cell via multiple mechanisms. The delivery of non-coding RNA in the site of bone loss through the gene vector or scaffold is a potential therapeutic option for bone defect repair. This study utilized a regulatory mechanism of microRNA signaling, mRNA delivery, vector, scaffold, and bone defect repair. So here, in the area of stem cell, there are upcoming era of metabolic cell-free for regenerative dentistry. So we exploit the metabolites from the stem cell culture that secrete soluble factor and consists of growth factors, cytokine, chemokine, extracellular matrix protein, hormone, and enzyme. As the important other supramolecule here is the extracellular vesicle that consists of contain microvesicle and exosome. And here, after we isolate the exosome, we can have the supramolecular like RNA, DNA, lipid, and soluble protein. After we harvest this soluble material or biomaterial or molecule, we can utilize this molecule to induce the cell for the proliferation, angiogenesis, or to prevent the overproduction of the immunoinflammatory. So we can also produce immunosuppression agent, yeah, and we can also prevent the anti-apoptosis and for reconstruction of some defect that lead by anti-apoptosis. So here the figure explain about the important cooperation between adipocyte, mesenchymal stem cell, osteoblast on bone surface, osteoclast, osteocyte, and monocyte and endothelial, and monocyte and endothelium during the bone regeneration. Here is the component of supramolecule that needed, such as microRNA, transmembrane protein, soluble protein, as I mentioned before. So for future application, after we preconditioning the culture of mesenchymal stem cell, so we can collect the secretome, and then we can make specific application for the clinical application such as anti-apoptotic, anti-fibrotic, immunomodulatory, or angiogenic, as I mentioned before. So the method we use here is molecular docking. So we predict the molecule that play important role in the bone regeneration, And then we pick the highest score of microRNA for bone regeneration and utilize automatic prediction of 3D structure of macrocomposer using this application and to construct a human SA microRNA 29B3P. And then the molecular dynamic simulation of this microRNA with bone morphogenic receptor 2 and chitosan with crosslinker of T4 lysozyme hydrogel using modified script can analyze how we predict the potential of this method. So the result, as we can see, we revealed that this microRNA that consists this sequence with 100% target score, serving major potential to stimulate osteoblast development and promising rapid extracellular matrix formation via the direct pathway. According to the protein alignment, and sequential pairing here, the target region prediction of the microRNA that we choose before is revealed that this microRNA could pair with score percentile 88 at chromosome 8 and the bind with bone morphogenic protein 2 to robust osteoblast process. So hopefully this simulation will help us to design the in vitro study. So for molecular interaction between this microRNA with bone morphogenic protein 2 crosslinker with T4 lysozyme, as we can see here, the docking score is about 96 to minus 101 for TL4. And here we can conclude that bone morphogenic protein 2 was applied as under fundamental receptor target of bone regeneration to stimulate the upregulated gene signal of osteoblast differentiation and preserve as homeostasis cell bone. And we utilize this microRNA to accelerate bone morphogenic protein 2 performance by confirming Townsend-specific docking, this docking. This generated by a doc application. So the result in this study, we have been successfully drawn that our microRNA protein network associated in bone regulation with their down and up regulation expression, and the highly secreted protein of gene were generated from BMP2 and collagen family, which 90% distributed to bone regeneration. As we investigated by docking, then molecular docking simulation, the bone morphogenic protein 2 and T lysozyme and chitosan and the microRNA well bound in aspartate amino acid, this amino acid, yeah, this is a kind of amino acid with the epitope, which could interact with two chain of T lysozyme chitosan, chain A and chain B, as the delivery system with sufficient equilibrium along the process. So for the future work, based on this molecular docking, we would like to resemble the hydrogel fabrication of chitosan lysozyme, yeah, and the mixture will be incorporated with microRNA, and we are developing the porous scaffold and hydrogen scaffold mixed together. So we are developing the injectable material for bone regeneration. So this is maybe the design for the experiment, and we adopt for Tingpan et al. In 2022. Here, Pang using the not chitosan but the polyethylene glycol, and instead of using the glutaraldehyde, because glutaraldehyde we think is cytotoxic to the cell, we replace the glutaraldehyde with the T lysozyme. Maybe something like that. And as a conclusion, we have revealed that docking and molecular dynamic simulation with bone morphogenic protein 2 and T-lysozyme 41 chitosan linker and the microRNA 29B3P will bound with amino acid. This amino acid in rich epitope. It could be interact with the two chain of T-lysozyme 41 chitosan as the delivery system with sufficient equilibrium along the process. Thank you very much. And this project is funded by the grant from the Ministry of Education and Research, the Republic of Indonesia. Thank you very much.
Hello, my name is Bassel Khrisat. I'm a consultant OBGYN and urogynecology. I'm head of the urogynecology unit at King Hussein Medical Center, Royal Medical Services, Jordan. I hope my presentation will be beneficial for all. My presentation will be about large pedunculated vulvar lipoma, a case report. Lipomas are benign tumors of adipose tissue. They arise from the superficial subcutaneous tissues of the trunk and limbs. Although they are in the superficial subcutaneous tissues, but they could be found in the peritoneal cavity and within muscles. They are the most common soft tissue tumors, ranging from 2 to 20 centimeters in diameter. Usually they are fluctuant, soft, painless subcutaneous lumps. And most of them are excised for cosmetic reasons. As I said, they are the most common soft tissue tumors, but the occurrence in the vulva is rare, and not so many cases were reported in the literature. Diagnosing vulvar lipoma typically involves the combination of medical history, physical examination, and doing a differential diagnosis in addition to some imaging studies and maybe biopsy. From the medical history, we should know the history of appearance of the lump and the behavior of the lump, and the symptoms associated with it. Physical examination, we should examine the general examination in addition to the appearance of the lump, the consistency, the mobility, and the relation to the surrounding tissues. And we should put a differential diagnosis to exclude other possibilities, and we can use imaging studies like ultrasound or CT or MRI. Biopsies, if we can just use biopsy if we have an atypical presentation or we have high suspicion of malignancy. From the differential diagnosis, we can they can be easily, most of them can be easily excluded by the history and physical examination. From the differential diagnosis, we can see the Bartholin cyst, which is fluid-filled cyst due to blockage of the Bartholin glands at the entrance of the vagina. Sebaceous cysts, they are oily filled cysts. Inclusion cysts, sometimes it is due to the presence of surface skin, surface skin into the beneath the skin. The most important is the liposarcoma, which is could be differentiated from the rapid history of a growth and from the histopathology, and other differential diagnoses like the lymphadenopathy due to infection, inflammation, or malignancies. Sometimes the genital warts, which are caused by strains from the HPV virus, may cause lumps like fleshy color or flesh color growths, in addition to other inflammatory conditions like folliculitis. The treatment ranges after reaching a diagnosis. The discussion with the patient about the management options should be done. The treatment ranges from leaving for observation if it's small and not bothering the patient, to the ultimate surgical removal of the lump. Sometimes we use liposuction through a small incision and using a narrow tube. If it's large or if it's deep with the surrounding tissue. Sometimes steroid injections could be used to decrease the inflammatory process and cause shrinkage of the lumps if they are small, but they are not a permanent treatment. Laser therapy also could be used to heat and shrink the mass. It leaves small minimal scarring, but they are used just for small lumps. No medication is reported to remove the adipose tissue, but sometimes we need to use anti-inflammatory drugs to decrease pain if it's present or if there is infection. Now we move to our case. She is a 33-year-old lady. She's para 2. She delivered both her babies by cesarean section. She doesn't have any chronic medical illness, and she has an unremarkable menstrual period. She presented complaining of painless mass protruding from the right side of the genitalia for the last 18 months. The mass started to grow when she had her last pregnancy, then increased in size till reaching this big size. She has no history of trauma or surgery at the site, and she has no history of vaginal discharge or decrease in weight or appetite, and no family history of such illness. But she was embarrassed to speak out, so she missed her appointment with her obstetrician and presented around 6 months or more from her delivery. This is the picture of her mass on presentation. As you see, smooth surface, pedunculated. Although she was counseled by her doctor regarding the management options of her mass, but she lost, as I said, she lost the appointment, and she was seen lastly at our clinic due to the bothering some issue of her mass that started to affect her life. After taking brief history, she was examined. There was a large pedunculated soft tissue mass from the right vulvar region, and it measures 14 by 13 by 10 centimeters. There was no change on the overlying skin except for ulceration in the most dependent area due to chronic pressure when she was sitting on it, but no bleeding from the area. As I said, the surface was smooth, mass soft, painless, mobile, lobulated, with thick pedicle. Her labs were unremarkable. She underwent ultrasound imaging, which confirmed the density of fatty tissue. decision was made for surgical excision after the discussing the management options with the patient. Through elliptical incision at the base, complete excision of the mass was done. We left some flap in order to close the wound. This is a pre-operative view, and this is the view with the small ulcer on the most dependent area where she was sitting on it. And this is the final view after excision. She was followed up and she has excellent cosmetic results. Mass was sent for histopathology, which confirmed the diagnosis of benign lipomatous tumor with features compatible with spindle cell lipoma present at the surgical resection margin. And this is here histopathology. Sections reveal a well-defined tumor, partially encapsulated, composed of a mixture of mature adipose tissue, uniform gland-looking spindle cells, and drop collagen fibers. Thin wall and branching blood vessels are seen. Focal myxoid changes are also present. The lesion is present at the inked resection margin. The overlying epidermis showing areas of ulceration and granulation tissue formation. No evidence of necrosis or marked atipia or increased mitosis. The histopathologists also, they did histopathological markers in order to differentiate it from further to exclude malignancy by doing CD34 Disman, which were positive in the spindle cells and positive S100 in adipocytes, which excluded the presence of myxoid liposarcoma, which is the most important to be differentiated from the our benign condition. I conclude vulvar lipomas are rare benign tumors. They are composed of mature adipose tissue. They could be easily mistaken for other conditions. They should be differentiated from the liposarcoma, especially myxoid liposarcoma. Ultrasonography is widely recognized as the primary imaging technique for lipoma, and the surgical excision is the main treatment option for this condition. Thank you. Any questions?